opportunity. Dissociative disorders, previously known as hysteria, with its cause being attributed to wandering uterus in female. However, with the advancement in the field of science and research, there has been shift from the spiritual and religious beliefs to the scientific basis for dissociation. Dissociative disorders are characterized by involuntary disruption or discontinuity in normal integration of identity, sensation, perception, affect, thought, memories, control over bodily movements or behavior. With a lifetime prevalence of approximately 10%, they represent a significant mental health burden. Therefore, deeper understanding of variables associated with this process can help in early identification and treatment, and one such variable is personality trait. These personality traits can be explained as individuals' unique way of interacting with the environment. These traits are present in every one of us in variable degree. However, certain traits have been found to influence the vulnerability, course, and outcome of this disorder. However, in Nepal, there is huge gap in studies regarding personality trait among patients with psychiatric illnesses, especially among those with dissociative disorder. Also in Nepal, due to socio-cultural factors, mental health stigma, and also due to fear of isolation from the community once the psychiatric illnesses are disclosed, people tend to attribute these illnesses to supernatural entities like Kul Devtas or Devi Devtas, so that these illnesses become more acceptable in the traditional society, which leads to seeking help from traditional healers or spiritual leaders, commonly known as Dhami, Jakri, Mata, or other unqualified practitioners. Pathway to Care studies thus provide insight into a broader mental health care system, which can aid in identifying and removing these access barriers. Our study thus aimed to explore personality trait and help-seeking pathway among patients diagnosed with dissociative disorder. It was a hospital-based cross-sectional study conducted in Psychiatry Department of Nepalganj Medical College, which lies in midwestern part of the country. It was conducted for 1 year duration with a sample size of 71. We included all those patients between the age group of 18 years to 60 years. We excluded those below 18 years of age because personality is not well developed until 18 years of age. And also, we excluded those more than 60 years of age because there is high incidence of cognitive decline in this patient, which may interfere with our assessment of personality. A structural performer was used to collect socio-demographic and clinical information. WHO Pathway to Care questionnaire was used to assess the health-seeking behavior, and the personality trait was assessed using Nepali version of Neo 5-factor inventory. The clinical diagnosis of dissociative disorder and its subtypes were done using International Classification of Disease 11 diagnostic criteria. Our study revealed a mean age of 27.2 with a standard deviation of 9. Most of the patients were from age group 18 to 24, followed by 25 to 34. There was significantly higher proportion of female patients, accounting for 84.5%. Most of them educated up to high school, Hindu, unemployed, married, from nuclear family and belonging to low socioeconomic status. Regarding clinical presentation, most of them had dissociative non-epileptic seizure, followed by transient possession disorder and dissociative motor disorder. Regarding pathway to care components, most of them first took help from native and religious healer, accounting for 56.3%, while only 11.3% took direct help from psychiatric services. And the most common healing method used by these native and religious healer were worshipping or puja, followed by physical tortures like hitting with hot instruments or sticks. And the duration between the first symptoms and contact with psychiatric services was delayed for 3 months or more in 63.4% patients. And the first person to initiate the contact were relatives and friends, followed by patient himself and herself. Regarding the personality components, most of them were high or very high on neuroticism, average on extraversion and openness, and low on conscientiousness and agreeableness. Similar to other previous studies, our study also revealed the demographic pattern, particularly vulnerable to stress, that is young, unemployed female. The higher prevalence among female may be attributed to both epidemiological trend as well as socio-cultural factors, because in conservative society like ours, emotional expression is often restricted for women, and this restricted emotional expression may lead to psychological distress, thus manifesting as dissociative or somatic symptoms. Low level of education, as observed in our study, is likely to contribute to poor mental health literacy, thus reinforcing stigma and reliance on non-medical pathway. More than half of the patients initially consulted faith healers, which may be the reason for significant delay in early psychiatric intervention. The help-seeking behavior observed in our study aligns with various prior studies conducted in Nepal, India, and Pakistan. For example, by Karki et al. In 2017 in Nepal and by Farooq et al. In 2022 in Pakistan, highlighting the consistent role of magico-religious belief system in shaping mental health behavior across the South Asian context. And most of the times, friends and relatives were the first to report the individual for help, reflecting the significant influence of family belief on help-seeking behavior. Most common presentation observed in our study were dissociative non-epileptic seizure, followed by transient possession disorder and dissociative motor disorder. This finding is similar to those studies conducted in Nepal and India. However, this pattern differs significantly from those conducted in Western population, where dissociative amnesia, dissociative identity disorder, and depersonalization and derealization disorder are more common, reflecting the influence of cultural factors in phenomenology and prevalence of this disorder. Our finding of high level of neuroticism in 69% patient is in concordance with the findings from various prior literature. This high level of neuroticism is most of the time links to emotional instability, which heightens the vulnerability to stress and thus maladaptive coping mechanisms like dissociation. Also, our finding of low conscientiousness, low agreeableness, and average extraversion in majority of patients aligns with multiple prior research. However, our finding of average on openness and most of the patient is in contrast with prior studies, which showed most patients high on openness. This may be as a result of cultural influence on this trait expression. However, a confidence sampling taken from single tertiary care hospital may limit the generalizability of our study. Thus, limited access to formal psychiatric services, puberty, lack of awareness, stigma related to mental health are responsible for delay in psychiatric care. Faith and religious healers are the first contact point for most of the times. Thus, strategies to integrate them into mental health care system by supervising and educating them could prevent inhuman practices as well as improve psychiatric referral coordination. Also, incorporating personality traits into our clinical practice can help in early recognition of individuals with this vulnerability trait so that tailored interventions can be done for them. Our study thus highlights the need of culturally adapted mental health education and community level intervention that's focused on reducing stigma and promoting early psychiatric care. Thank you.